Already, there are more than 250,000 Ontarians living with dementia. That number is, of course, expected to rise and keep rising as the population ages. And many of those people will need care. But after a pandemic that put unimaginable pressure on our healthcare and long-term care sectors, where will that care come from? And can home care be part of the picture? Let's ask. In Edmonton, Alberta, Charlene Stewart, president of SEIU Healthcare. That's a union that represents more than 60,000 healthcare workers. In Peterborough, Ontario, Dr. Jennifer Ingram, researcher and medical director of the Kawartha Centre and specialist in geriatric medicine. And here in our studio, Dr. Linda Lee, a care of the elderly family physician and executive director of MINT Memory Clinics, and Saskia Sivananthan, Chief Science Officer of the Alzheimer's Society of Canada. And we are delighted to have you two here in our studio and our guests in Points Beyond joining us for a very important and timely discussion about the state of dementia in our province. And just before we start, I'm going to do one of these full disclosure things, which I occasionally have to do when we discuss healthcare. Dr. Ingram, you in Peterborough were part of Provincial Geriatrics Leadership Ontario. Apparently my wife, who's a health policy consultant, did some work with your organization once upon a time. So we put that out there in the interest of full disclosure for anybody watching who cares. Okay, that having been said, Sheldon, if you would, let's bring up this graphic and just give people a sense of the lay of the land as it relates to dementia these days. Currently, there are more than 600,000 people living with dementia across this country. In the year 2020, there were 124,000 new cases of dementia diagnosed. Let's look forward. By the year 2050, there'll be an estimated 1.7 million people who will be living with dementia. And just to make sure that we all understand what we're talking about here, Saskia, let's go first on this. Dementia, I guess, is an umbrella term, which means a lot of different things. So give us your best and simplest definition of what we're talking about here.
Sure. So think of dementia sort of similar to the way we would say cancer. It's an umbrella term for a range of diseases, up to 200 types of diseases that can have memory loss associated with it. Alzheimer's disease is the most common, along with vascular dementia and then a range of others.
And what's the most compelling theory as to why we seem to be seeing so much more of it these days?
An aging population. Age is one of the strongest risk factors related to dementia.
Jennifer Ingram, is dementia easy to diagnose?
Dementia is not, I wouldn't say easy to diagnose, but generally speaking, it becomes very self-evident to the families that we deal with. And if the history is presented to physicians, it can be relatively easily identified. It's more difficult if it gets very complex, if the individual has multiple conditions. And there is a process that we teach everybody to go through to make the diagnosis, whether they are in a primary care setting or in a specialist setting or on a team. It needs to be identified. Unfortunately, it's often not identified in a timely manner, and that's where Linda and I have done a great deal of work.
Let me do a quick follow-up with you. Do you believe there is still some stigma around a diagnosis of dementia?
Oh, there's terrible stigma around the diagnosis of dementia, and most of us working in the field work hard to make people live their lives fully and to avoid feeling the stigma as much as they do. It will take quite a bit of societal change and a great deal of improvement in the care system to allow people to live fully out in the community. And that's really where most of us in the world of dementia care hope to see the healthcare system move, is into the community in a fulsome manner.
Well, let me pick up on that with Linda Lee, because I think we've probably got 6 hospitals within a 15-minute drive of this studio. But I want to know what it's like if you've got dementia and you're living in a rural or remote part of Ontario. What are your chances of getting served under those conditions?
It is challenging. It's challenging for lots of reasons. In primary care, the system of care doesn't support the time and the expertise that primary care family practice has to make an early diagnosis, particularly early on in the stage of conditions when many different things can affect memory and can cause memory symptoms. So getting that timely diagnosis, getting the interprofessional care team that can help with that diagnosis, a physician that's knowledgeable in that area, to make the diagnosis, which is the gateway to services and supports in the community that help people to stay at home longer. That's a challenge in some of the more rural and remote areas.
And when you say a challenge, does that mean there are simply parts of this province where you're not going to get served?
Well, that's changing, and some of the work that we've been doing as well has been to try to make a more timely diagnosis to enable primary care to do a lot more so that people can get that timely diagnosis and a plan of care, services and supports in place early on to prevent crises that result in healthcare destabilization and use of hospitals and long-term care transition. There's a lot of work being done right now to help that along.
Gotcha. Charlene Stewart, we've had you on this program many times because you represent the, well, what should we call them? The front lines. You represent the frontline people who are dealing with this issue every day, trying to help people through the difficulties of dementia. Talk to us, if you would, about some of the pressures that the people you represent are facing as they try to do their work.
Yeah, absolutely. It's nice to be back, Steve. We've been having so many conversations about the crisis in healthcare. This is a real important topic, and we need to have more conversations with decision makers at Queen's Park about this. My panelists saying about the early intervention and being able to diagnose, that's what home care providers do. It's the continuity of care to begin with, that when a home care provider is visiting residents at home or clients at home, being able to have that continuity would mean full-time jobs, which, we have a human resources crisis right now. But that continuity means that me visiting a home, I get to know the client very well and can quickly identify those changes in personalities, in, emotional activities. The early intervention and early diagnosis is so critically important. And because we've got such a critical staffing shortage, home care actually is in my opinion, one of the most essential services, but yet it is one of the most neglected services. We don't pay enough attention to home care, and we have to change that. All the stats is that populations are doubling. We're the baby boomers. We are not being proactive in doubling the human resources that we need to take care of people at home and the aging population.
I will follow up with you in a few moments about that HR crisis that you just described. But Jennifer Ingram, let me get you back in here because, of course, if people can get served at home and be in their homes, that's preferable, obviously, to being warehoused in some institution where you don't want to be. So talk to us, if you would, about what supports are in place for those who can and want to be at home and receive services.
Well, I wish this scenario was different, but it's not. Like our healthcare system in general, the home care services view acute episodic illness as the place where the bulk of the investments have gone. And dementia is not an acute episodic illness. It is a long-term and developing illness. So most of the individuals, even with a mild dementia, where they may have trouble with a little bit of food preparation, shopping, banking, may need help in the home, but don't receive it. The place where the home care services are identified as being necessary is in the personal care area, where the basic activities of daily living are affected, the bathing and the dressing. And this is always justified on the basis of safety, as if this is a more unsafe time in the trajectory of care. But in fact, right from beginning to end, for the decade of dementia, most individuals who want to live at home, especially if they don't have a family member with whom they live, need little bits of care that gradually increase, and supports such as day programs to gradually increase to support them in that journey. Home care does not. It comes in late in the game. It offers time-limited service. It offers service that is disruptive and not consistent, with different care providers coming in and multiple care coordinators. Just with a quick vignette, tell you that a patient I had who died at home with dementia, in addition to private services that they had 6 home care coordinators in the final 3 months of life. Not all of whom thought they were doing their job well, but the individual who was the patient's husband called them by number, not by name. He couldn't keep track of the coordinators, let alone the service providers that were coming into the home. And that system is just not appropriate. It doesn't make any sense to anybody and has to change.
Oh, I get you on that. And 6 is clearly not ideal. But Charlene, do we live in a world where it's reasonable to think that we'll only get 1, not 6?
Yes, I truly believe that. And there are true examples of it. The first thing we have to do is recognize that home care is skilled work. We just have to give it the recognition and allow them to provide that skilled work. You can have full-time work. You know, I often have conversations with ministers of health saying, we need to treat this service not like gig workers. They aren't just casual workers that come in and out. Let's use EMS services as an example. You know, firefighters are in the hall and, you know, we don't want them to always be fighting fires. But when they're there, they're upskilling their skills. You know, they're taking, online services or practices. The problem with home care is that they treat it like gig work. We have to provide decent job conditions, meaning full-time work. Our problem is we have to recruit them and then we have to keep them. There's so many missed visits right now, which adds to those numbers because these home care workers literally cannot afford to go to work. They don't get paid for mileage. They don't get paid while they go from client to client. And again, I'll say the decision makers at Queen's Park, they get their mileage. They get their gas in their car when they're visiting their constituencies. They get full wages no matter what they're doing, if they're sitting in their office or they're out in the community. We need to give home care services the same respect that they get for all kinds of reasons. Institutional care, whether it's hospital or long-term care, costs so much money. You put even half that amount into home care and watch the care be better, and the offloading of those expenses from the hospitals and put it in community. People want to stay at home, and you'll get early intervention and early diagnosis because I am taking care of you on a regular basis and I can identify those needs quickly.
Saskia, I want you to give us a sense of your best estimate as to what percentage of people with dementia can cope at home with additional home care and what percentage really need to be in a more formal long-term care facility / institution.
Well, I mean, people living with dementia have been very clear. They want to be at home for as long as they can, to be engaged in their community as long as they can. And it really depends on the trajectory of their disease. It's a neurodegenerative disease, which means as people age and as the disease progresses, they need more and more care. But to Jennifer's point, that care can slowly increase. It doesn't need to be this huge influx right at the beginning. And then depending on their needs, you can have more care, home care supports, you can have more community supports. But part of the conversation that we also need to talk about is caregivers. We call them informal caregivers, and these are family and friends.
I'm going to cut you off because we're going to get there.
Okay.
We're going to get
All
there.
right.
But I want a better sense about the size of the problem right now. In terms of, like, are most people able to be at home, or do they really need to at some point go to an institution?
Most people are able to be at home, but I don't want to take away from the fact that as that disease progresses, it gets to the point where some people do need long-term care. Right. But the vast majority can remain at home with the right amount of supports, as well as supports for their caregivers.
You got to figure out what the right amount is.
Exactly.
That's the trick. Okay. Tell us about some of the work you're doing, because you've got some intriguing things happening at MINT.
Oh, well, thank you for asking. Yeah, MINT Memory Clinic is a not-for-profit organization that trains healthcare professionals in primary care, that is in family practice, to better manage to better care for people who are living with dementia and their family members. The training helps to deliver the needs that people need in the community living with dementia, and avert those crisis events, the healthcare destabilization that results in hospitalization and long-term care use that's so costly for the system and causes so much suffering for people. There's about 100 memory clinics in Ontario, and there's many in BC, Alberta, and Saskatchewan as well. About 1/5 of Ontario has access to MINT memory clinics. And
why so few?
A lot of it is funding. We're a non-profit, and we are dependent on grant funding. And we're hopeful that the Ontario government will support the spread of MINT clinics. There was a provincial evaluation in 2019 done by the Ontario Ministry of Health that showed that if people have MINT clinic care, that they have better health outcomes, they're able to stay in the home longer, and there's much less healthcare system use, less hospitalization, less long-term care transition, and in fact, there's much less cost to the healthcare system. And by some modeling, if every Ontarian who has dementia received MINT clinic care, it could save the healthcare system $3 billion annually. There's $3 billion annually in healthcare cost savings that could be redirected in to provide much more home care for people in the community. So we're hopeful that the Ontario Ministry of Health will fund MINT memory clinics to spread so that every Ontarian has access. It's a homegrown solution to help with the healthcare crisis.
Here's what the Ministry of Health had to say. We contacted them to get some information about what they're up to, and they said in the year 2020-2021, annual support for home care totaled $3 billion, and that in April they committed an additional $1 billion over 3 years to expand home care. This would go towards supporting home and community care services, hiring nurses, retention incentives, that kind of thing. And Charlene, this is where we're going to circle back to the point you made earlier about the HR crisis you're finding. Do you think that kind of money is sufficient to get people either into this line of work or staying in this line of work?
Unfortunately, Steve, I don't know, because we do not get reports on whether or not that money is truly going to the frontline in home care. The feds, as you know, gave a lot of money to the provinces. They said it had to go into mental health and home care, but there's no tracking of that money. There's no accountability. So they say that they've got these initiatives, but all I know for sure, the true data that I have is what I see on the front line. And we are in a critical human resources crisis right across the healthcare system. And home care, I mean, we could double the amount of home care workers we have now in 2021. When you hear the stats of 2030, which is only 8 years away, we need to double that. So we need almost 250,000 home care workers. And right now, the data that I have shows that we have about 130.
So where are we going to get the rest from?
Again, we have to start being proactive, start to show these critical skilled workers that we need them to come back into the field. We need to give them decent wages. We need to give them full-time jobs. We need to provide them with continuity of care themselves, meaning that they have continuous care with the same clients, not being called all over the province and being called on short notice. So we need to improve the working conditions, and we need to respect home care as a skilled essential service. Right now, they're going to long-term care, and long-term care is going to hospitals. They're following the money, and they're following the continuity of full-time work. We need to treat home care like we do our hospital staff and long-term care staff.
Saskia, I'm wondering what happened during COVID when we were all locked up in our own homes and home care visits were sort of not allowed. What happened then?
Home care was decimated, is actually what happened. We have a national dementia info line, and we saw a 10-fold increase in the number of people living with dementia and caregivers calling us in absolute crisis because they didn't have home care workers coming in, their hours had been cut back entirely, they didn't have the supports they need, and yet they still had people living with dementia at home that needed supports. And then, of course, long-term care saw well, we saw the devastation
Sure
there,
did.
and it was mainly people living with dementia who died of COVID. But when you come back to home care, when you have that level of cutback in terms of hours, staff, PSWs who were not given the right kinds of supports, and to the other panelist's point, it's gig work. They were going to multiple homes. They were not being given enough hours. They were having to see multiple clients. The caseloads went through the roof. And now, even though the pandemic restrictions have started to ease up, we're still having clients who are struggling, who are not getting the right kind of care and the right number of hours to support them at home. One of the examples is Faye Forbes, who's a person living with dementia who was on our board of directors. I was talking with her just
Where's she from?
last week. She's from Nova Scotia in Halifax. And she told me that before she has anyone from home and community care come to her home, she spends all day preparing for them. She's got to move things off the table. She's got to shift things everywhere so that they can come and clean and Swiffer, because there's very specific restrictions around what they can and cannot do. And can you imagine having to spend all day worrying about that before the person comes in to help you? That's not what home and community care needs to be. And we have other examples from other countries where we know it works if we invest appropriately.
All right, now I want to circle back with you on a follow-up. You were talking earlier about care partners or carers. Again, give us a basic definition of what you're talking about here. Who are those folks?
Sure. So we published a report recently that started to delve in to look at what caregivers of people living with dementia look like, and there will be a second one looking at that more deeply. But they're called informal caregivers or care partners. But the kinds of supports they provide are everything from coordination to activities of daily living, supporting a person to get dressed, bathe, managing their finances, being able to get to all of those different doctor's appointments, specialist appointments. Caregivers are doing everything. And what we've seen is in the report, we're looking at about 350,000 caregivers.
We got the numbers here.
Yes.
Stand by. Sheldon, bring this up if you would. Middle of page 3. Sorry, Saskia, I'm taking over here.
No problem.
But you were just about to say this. Here we go. This is, in the year 2020, an estimated, as Saskia said, 350,000 care partners in Canada. They're working an average of 26 hours a week, amounting to 235,000 full-time jobs if you think of 40 hours per week with 2 weeks vacation. My goodness, that's a ton. Amounting to more than $7.3 billion worth of labor if you consider the federal minimum wage of $15.55 an hour. And by the year 2050, we've talked already about the fact that all of these numbers are going up by a lot. The report projects there'll be more than 1 million care partners, 1 million caregivers in this country. Well, okay, we've talked about supports in place for the people who need the care. Jennifer Ingram, how about you coming in here and telling us what kind of supports are in place for the people offering the care?
Well, the informal caregivers rely heavily on the Alzheimer's Society for supports. And this is one of the reasons why Dr. Lee and I have both nurtured the Alzheimer's Society community support individuals into our assessment clinics, so that early on in primary care, people meet somebody who is representative of the kind of care that's available in the Alzheimer's societies for the care partner in particular. But care partners require many things that aren't offered by the Alzheimer's Society that need to be offered by the home care system. They need consistency of individuals, they need predictability of timing, and they need to be able to access a knowledgeable person when things change. And the home care system as it's set up, in essence, makes it very difficult for care partners to keep ahead and to feel empowered to do the work that they want to do. Care partners are a wonderful resource. I would never want to imply that they are going to be the only resource, but if we had used care partners more knowledgeably during the pandemic, some of the deaths that occurred by virtue of neglect may not have happened in the institutional environments that were very restrictive to families and care partners visiting. But the same is happening at home. Care partners aren't always there, and over 50% of our individuals with dementia live alone. So care partners cannot provide the needed gap in home care. We need a system rethink. We need to incentivize people being cared for in their home. Currently, approximately 40% of all admissions to long-term care come through hospitals. So there's an incentive in the basic system we're working in for people to go to hospitals, and that just should not be there. We should incentivize people to stay at home, and to do so, we have to incentivize and train the workers, provide them with the knowledge, and make them part of a team. Geriatric care is a team sport. You need a team to make it work. Just home care isn't the answer, and just a doctor isn't the answer. It's the team that works together to make it all predictable and consistent. And access for all when needed is where we need to go. We need to be a little Denmark.
I gotcha. I want to follow up with Linda Lee on this, which is if you are living alone and you don't get that consistent level of care we just heard about, what's the downside?
Without that consistency of care, it's very easy to have the health destabilization, both for the person who's living with dementia and their care partner. Without that constant care, a team of healthcare professionals that know what services and supports need to be in place in a proactive way. I completely agree with Dr. Ingram and with Charlene's comments. Our system is crisis-driven. It's a very expensive way to deliver care, and it's not humane care for people living with this condition. It's to be proactive, to get services and supports in place early on, integrated into the system of care by a team of people in primary care, because that's where most older adults receive their care, is in primary care. An integration of the specialist care, community care, Alzheimer's Society, home acute care into the primary care system by a team of people that the person living with dementia and their family members become comfortable with, that can avert those crisis events, help them stay in the home with their best quality of life, avert the hospitalizations that are so awful for people and worsen cognition and just that trajectory into long-term care. If we can avert these health crises, as some of the work that we've done and the Mint clinics have shown, it really does reduce the healthcare system costs, and then that can be redirected into the home and community care that is so necessary for these people.
I know there's an assumption probably by our viewers and listeners that we're talking about people right now in their 80s and 90s and beyond. But I do want to play a clip here from somebody whom I suspect many of you know, Lisa Raitt, a former deputy leader of the Conservative Party of Canada, former member of Parliament, cabinet minister. And she was on this program not too long ago talking about her husband, Bruce, who's not in his 80s or 90s. He's a young man, and they're going through this. Sheldon, if you would, the clip.
What do we not know but need to know about what life for caregivers is like?
That it's 24/7. That it really does take a toll on you emotionally and physically. And a lot of the times when you're young, you're put, or youngish, in your 50s, 60s, especially when it's a spouse, you are put in the position where you early retire, you take a part-time gig, you drop off in hours, you start not producing as well at work, and it has a real impact on you as an individual and on your career and on your trajectory of your career. And I think that's the piece that I'd like folks to understand from an economic point of view.
Talking about her husband, Bruce, who's, I guess, still in his 50s and lives in an institution right now because that's what he needs at the moment. So, Charlene, let me get you back in here. What do you think can be done to support care partners like Lisa Raitt, who are going through all of this, maybe don't have the PSW or nurse support that at home that might have been helpful?
Yeah, that's a really heartbreaking story, and unfortunately, it's very, very common. They do need a lot of supports, the family caregivers, and that should come directly from the government as well. They could be subsidizing resources like income, particularly. That's one reason why people struggle. They do try and balance a full-time job and taking care of their loved ones. We've talked to the governments about that a lot, giving a family caregiver like resources, like a wage, that type of stuff, and access to all of these other great institutions. I mean, we've witnessed some severe cuts in some of those services. They need to be reinstated. Families need a helpline for sure. And I'm just going to emphasize again that home care is absolutely a solution that we are ignoring, and it's terrible that we are. It is skilled work. They are available, and I have to tell you, they are really unique, special people that do home care, traveling from home to home. And I just want to add too, it's not uncommon either for a home care worker to go into a home to take care of a client with dementia, and their spouse will be suffering from the same or onset. So yeah, I hate to say it, but I think it is a common sense, rational solution. We just have to get the people, the decision makers, to be bold enough and committed enough to put the resources into this.
Well, I wonder, Saskia, if we talked at the beginning about how the numbers are sort of, they're going to be skyrocketing over the next little while. Is that inexorable, or is there anything we can do actually to level off that number?
Well, there's certainly hope. Research, we've known that there have been some pretty high-profile clinical trials around, Alzheimer's, dementia therapies that have failed or have not done as well as one would hope. But the research has progressed quite a bit in risk reduction. So that's just understanding better some of the things you can do to improve your brain health and to hopefully be able to delay the onset of dementia. In the report, we modeled what could happen if you could delay dementia by even a year or by 5 years. Now, how you delay it, it could be anything. It could be risk reduction. It could be therapies, a range of things. But even delaying dementia by 1 year reduces that number of Canadians by 500,000 living with dementia.
So start doing your crossword puzzles right now.
That's one of those, for sure. But there are 12 recommendations that we have in the report, and there are things that are very specific to dementia, like sleep. Making sure that you try and get a good night's sleep, addressing hearing loss early, which has come out as a very strong factor associated with dementia. But to the other panelists' point, home care is one of the areas that people living with dementia have said they want to be able to stay at home and to live as well as possible with dementia, because it's not a done deal. Once you have a diagnosis of dementia, that's not it. You don't go home and wait to die. But that's often the kind of message that people feel they get. And we need to remove some of that stigma so that they understand that you can live well with the disease at home and in your community.
This was a great discussion. I want to thank all four of you for coming on to TVO tonight and sharing your expertise and your views on this. Charlene Stewart, Jennifer Ingram, Linda Lee, Saskia Sivananthan. Thank you, everybody.
My pleasure.
Thank you. Thank you for having us.
The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.